Hi, I'm Dr. Raquel Arias, Associate Professor of Obstetrics and Gynecology at the Keck School of Medicine of the University of Southern California. In my experience, successful use of Mirena begins with counseling. Counseling helps to set realistic expectations. When counseling, it's critical to keep the woman's individual needs in mind and to tailor each counseling session so that she isn't overloaded with too much information. When counseling a patient who seems right for Mirena, I usually discuss the basics, including the high efficacy rates, its safety, and the convenience of non-daily contraception. Mirena provides compliance-free contraception with 99.9% efficacy. Most importantly, there's almost no risk of behavior-related failures. It's also important to counsel patients on Mirena safety profiles. Patients should know that Mirena does not protect against sexually transmitted diseases, including HIV. Showing the patient the actual Mirena is extremely helpful in overcoming some of the fear factor associated with intrauterine contraception. I emphasize the small size and soft, flexible plastic design with this demonstration Mirena so she can see it for herself. Patients usually inquire about the placement procedure, so I always mention that the placement and removal of Mirena is performed right here in the office during an office visit. Patients find it comforting that Mirena insertion is a non-surgical procedure that does not require a hospital stay. Cost also comes up in my patient consultations. I tell my patients that Mirena is actually more cost-effective than other contraceptive options after just 1 year of use. There are also payment plans available. Patients may opt for a single payment or a 4 or 12-month payment plan. This makes Mirena affordable to many more patients. Many women seem to be good candidates for Mirena, including new mothers, family planners, and family completers. Mirena is an excellent option for these patients since Mirena offers reliable, removable, and cost-effective contraception. With new mothers, I often start the contraceptive discussion early, during her prenatal visit. This allows time to determine if Mirena is right for her. I also discuss the wait time of 6 weeks postpartum. It's important to know you must wait until involution of the uterus is complete. By waiting 6 weeks or until involution of the uterus is complete, we can reduce the incidence of expulsion and perforation. If involution is substantially delayed, I'd wait about 12 weeks postpartum to insert Mirena. Women who want to plan the births of their children are also great candidates for Mirena. These women are often overlooked as possible intrauterine contraception users. However, they're usually good candidates because they're looking for a contraceptive they don't have to think about every day or every month, and one that's easily removable. Mirena makes sense for many of these women. Many healthcare providers prescribe Mirena for family completers. These are women who believe they've completed their families but may not want the permanence of sterilization. I often discuss intrauterine contraception as an alternative to sterilization with these women. Did you know that 1 in 4 women who chooses sterilization regrets her decision? This is especially true if she's under the age of 30. The fact that Mirena is a regret-free, non-permanent option makes it a good choice for these women. As I mentioned before, Mirena is removable, so regret's not an issue. Now I'd like to talk to you about pre-insertion counseling. Understanding how Mirena works, the placement procedure, and what to expect after insertion helps to increase the patient's comfort level with Mirena. I find it helpful to show patients how Mirena works with the use of this uterus model. The contraceptive effect of Mirena is in part based on the local effects of levonorgestrel in the uterus, the thickening of cervical mucus, and the inhibition of sperm motility. These mechanisms prevent fertilization and prevent endometrial growth. While reviewing these modes of action, many times patients comment on the size of Mirena. Many patients are pleasantly surprised to see actually how small and flexible it is. I also find it helpful to provide patients with educational materials on Mirena, such as the question and answer booklet and patient education DVD. These materials provide more details on what to expect with Mirena and help answer commonly asked questions. I then provide her with a copy of the Mirena patient information booklet and consent form to take home to read. This is important and allows her time to review the consent form prior to signing on the day of insertion. We also discuss the appropriate time for Mirena insertion. Mirena is usually inserted within 7 days of the onset of menstruation during a routine office visit. Setting expectations regarding bleeding is very important. I discuss the changes in bleeding patients may experience, such as intermenstrual spotting or bleeding, during the first 3 to 6 months.
So what happens after you place the Mirena?
After Mirena is placed, you'll notice a change in your monthly period. During the first 3 to 6 months, your period may become irregular. You may also experience spotting or light bleeding, which may require sanitary protection. As your body adjusts to Mirena, the number of bleeding days is likely to decrease. At 3 months, there may be up to a 75% reduction in bleeding, or your periods may stop altogether. About 20% of women have reported having no periods at all after 1 year of Mirena use.
Is it really okay if I don't get a period?
It's a common misconception that your body needs a monthly bleed. It's perfectly fine not to have your monthly period while using Mirena. Every month the lining of the uterus thickens during the first half of the menstrual cycle. The levonorgestrel in Mirena reduces the monthly thickening of your uterus. Less thickening means less menstrual flow. Absence of a period is not harmful to your body, so you shouldn't worry. Are you comfortable with this?
Yeah, now that I understand why it happens.
But as I mentioned, irregular bleeding and spotting may occur during the first 3 to 6 months of Mirena use, and I'd like you to track these changes. This is a Mirena diary. I'd like you to use the diary to keep a record of your monthly bleeding once Mirena is placed. You should bring the diary back with you on your follow-up visit, which we'll schedule today.
Perfect.
As for side effects with Mirena, I mentioned that some women experience cramping in the first few weeks after insertion, and that a non-prescription pain reliever, such as an NSAID, can usually overcome any discomfort. I instruct my patients to contact me at once if they have any fever or significant abdominal pain, particularly within the first few weeks after insertion. I also want to know if they miss a period during the first few months of use, have an unusual vaginal discharge, or suspect exposure to an STD. Besides menstrual changes, some patients may experience hormone-related side effects such as headache, nausea, moodiness, skin breakouts, and breast tenderness. These side effects often go away within the first few months of use. I also make sure to mention that Mirena is estrogen-free, so there are no estrogen-related side effects. While unlikely, there's also the potential for expulsion and enlarged ovarian follicles. Enlarged ovarian follicles have occurred in about 12% of patients. In most cases, these follicles have resolved spontaneously in 2 to 3 months observation. I always review the potential complications associated with intrauterine contraception, including pelvic inflammatory disease, infection, uterine perforation, and contraceptive failure. Pelvic infection associated with contraceptive use is very rare and comparable to the general population. The first-year contraceptive failure rate for Mirena is 0.1%, making it one of the most effective methods available.